All right. Thank you again for staying with us today. Excellent discussion so far. We'll move right on to the next session. Home stretch for us. So the next session is entitled Heart Valve Disease. What does the future look like? Part of this is what we think future heart valve therapies will look like. Part of this is a little bit of potpourri of heart valve disease. And really the third aspect of this is we couldn't figure out where to fit this in the first or the second session. So our first speaker is also our Twitter czar, as I refer to him, Dr. Josh Levenson, who is an imaging expert and a cardiologist with the Heart and Vascular Institute. He's one of the directors of the Echo Labs, is the director of cardio-oncology, and one of the associate program directors for the Cardiology Fellowship. So thank you, Josh.
Thank you, Ebes, and thank you all for giving me the opportunity to speak. I wanted to spend the next 5 to 10 minutes really asking the question of whether we should be treating, meaning intervening on, moderate aortic stenosis. And Ebes gave me the title, What Are We Waiting For? And let's see if I can move forward. Here we go. So the philosophical question, again, is how should we define severe aortic stenosis? And I think you will be able to think about this topic a little bit if we take this null hypothesis question. Here we go with my slides. Thank you. There we go. We'll go back. So the null hypothesis here is that severe aortic stenosis has been traditionally defined correctly as an aortic valve area less than 1 centimeter squared, and a mean gradient by echo as more than 40 millimeters of mercury, and that these are the right patients who should be getting an aortic valve intervention just before or right as they are getting symptoms from their valve. With the idea being that historically, our traditional paradigm has been we have valve degeneration, and we have asymptomatic stenosis, which becomes severe, followed by symptomatic severe stenosis with angina, heart failure symptoms, syncope, and if we don't intervene, death. The concept, which we're all familiar with, has been disease progression in the valve leaflet with calcification, and you could see a normal valve with mild leaflet degeneration followed by moderate and then severe calcification. And ultimately, as there is more and more calcification, we have then limiting the ability of the valve to open. The traditional paradigm dates all the way back to the 1960s from this classic, really Kaplan-Meier curve, which we presume was from predominantly bicuspid valves, although we don't truly know. But mortality from medically treated aortic stenosis was that of very limited mortality until the very late stage, and then these patients would progress within 2 to 5 years of severe symptoms followed by death. The question that I want everyone to think about is, how do we define aortic stenosis? And if we go back to the 1990s, looking back data from Catherine Otto and her team looking at valve disease patients who did not have symptoms, they did echocardiographic evaluation and exercise predictors and followed them clinically. And what you'll notice, which I think has really predominantly defined the way we define valve disease these days, is that we can use echocardiography with a peak velocity, a continuous wave through the valve, to determine true risk of fatality and need for intervention based on the peak velocity. And so this has been some of the predominant data showing that a peak velocity over 4 correlates mean gradient over 40 as having the worst prognosis. What's worth noting here is that the patients who had a peak velocity between 3 to 4 meters per second were not free of disease. They have quite profound progression to events within several years, which is very different than the patients who had a peak velocity less than 3. And this variability in the rate of AS progression it was quite individualized. Here are just 8 patients, and you can see some of these patients had marked rate of progression, whereas some stayed quite flat. And more recent data from Harlan Krumholtz's team looked at large volumes of patients to say maybe we could use the rate of progression to determine who is truly the highest risk, and then identify those as those who would need to intervene. And you can see here, if we smooth out this individual data, we can see that some patients truly stay quite stable over many years, and others progress very quickly. And the need to intervene on these patients based on traditional criteria does really have some prediction from this progression. But the overall rate of death was actually very similar, suggesting that maybe this is the same phenotype going on underneath all of this data. In addition, it's worth noting that the outcomes for these patients in other cohorts really is predicted based on the valve velocity. But if you notice, even in these patients with aortic valve disease from a large number of international clinics, there's not a freedom from severe symptomatic disease or death despite having a valve velocity less than 4, suggesting that there may be severe pathology going on underneath all of this. And another nice long-term survival in patients with moderate aortic stenosis shows that these patients over 5 years have a quite high mortality despite having valve gradients less than 40 millimeters of mercury. And as my colleague Dr. Kleiner always says, these are not necessarily patients who have low flow severe AS. There are patients out there in the world who have truly moderate aortic stenosis that meet the traditional criteria. And despite that, you can see in the purple, they behave almost the same long-term survival-wise as those who have a velocity over 4. So this makes me wonder, and I think others have as well, about whether we should be changing the way we define aortic stenosis. And a large group of clinical registries have used a more novel staging criteria that suggests we should not only be looking at the valve, but also at the myocardium, at the phenotypes of the left atrium, and the right heart, and ultimately right heart damage that can occur as a result of aortic stenosis. And here's just this broad staging schema from 0 to 4, and multiple papers have shown that this independently predicts outcomes. So maybe we shouldn't be focusing on the valve and look at other criteria. Regardless, we know that novel imaging modalities can better define whether valves are truly calcified and degenerative. CT has really helped us show this. I think you can see a nice cross-section of a valve that has leaflet calcification. And here we see 2 different patients, one with mild aortic stenosis and one with severe, based purely by aortic valve calcification, suggesting that maybe we should be using CT to define this, and I think multiple registries have shown that. And I think, as we saw from Dr. St. Hilaire, that we have an active process going on in these valves, and so maybe what we need to do is really look at imaging from a different modality. The long story short is that we need to continue to find novel ways to find patients who have valve disease that needs to be intervened on. And if you look at the novel criteria that have evolved out of the European guidelines, traditionally, we would use a valve gradient over 40, a velocity over 4, and an AVA less than 1. But in the 2017 guidelines, we really allowed for a little bit more stricter approach. And to qualify for time here, I'll just show that when we were a little bit stricter, we were able to declassify patients from severe AS to moderate AS based on the 2017 guidelines. And that actually took a large number of patients here, almost 25 to 30%, were reclassified. Yet despite reclassifying those, they did still behave as if they had higher risk, saying maybe these are patients who really aren't moderate and need to intervene on. And for the sake of time, I'll say there are ways to risk stratify these patients, but it's leaving me wonder whether we should be treating these patients with moderate aortic stenosis. And the answer is we need data, and we don't have a data set that I think answers this with a randomized trial. And so this is a plug that I don't have a true financial bias in this, but I am inquisitive and wondering whether these are the right patients we should be doing TAVR on. And this trial, the PROGRESS trial, is going to answer that question. Nationwide, this is actively randomizing, and we're excited to be part of that trial here locally. And you can see we will be taking traditional moderate aortic stenosis patients and randomizing them to TAVR to see whether these are the right patients who will benefit. Thank you all.